So, Charles, how soon do you think you will um, have all of your credits and everything and be a nurse practitioner?
Um, so I've got a capstone course, and I've got two sets of clinical and the pediatrics. I wasn't able to get pediatrics rotations for my NP
Mm,
because of
okay,
COVID. So I'm at the end. So yeah,
that's exciting. You're at the
yeah,
really fun part, I think. At least that's how
yeah.
I was in your shoes.
The scary part too. It's like, oh, no, it's gonna get real.
Definitely going to get real. But I'm sure all your experience as an MDS nurse and as an RN will kick in and be a huge asset to you.
I hope so. The nurse practitioners I've worked with that had done that before, they come into the building with a very different set of eyes,
Hmm.
and it was interesting to see their impact on the building. So I'm hoping that that's kind of where I'll be.
All right. I'm excited to get into the PDPM with you all. Welcome to LTC Heroes. My name is Peter Murphy Lewis. Many of you might know us from the podcast, and you might already know my first guest, Melissa Brown. She joined me last week on the live stream. She's the Chief Operating Officer at Gravity Healthcare Consulting, and she's a PDPM nerd. Self-declared. I remember the first time that she was on the show, and she said, I'm so excited to talk about PDPM. I'm always excited to talk about it. And that's why everyone in her network calls her the PDPM nerd. The second guest I have with us today is Charles Oliver. Charles Oliver is the Director of Customer Success at Experience Care. And to get the ball rolling, I want to quote what Charles said to me the other day when we were preparing for this interview with you two PDPM geeks. And he said, quote, I love PDPM. For me, if you do it right, you use it right, better care for everybody, end quote. Melissa, would you agree with that quote?
Yeah, I couldn't agree more. I'm amazed really at how well CMS designed PDPM to reach their end goal. And I think one of the things that gets me the most excited is even though I'm a therapist and the old system used to really favor reimbursement towards giving more and more therapy, I like that now it's a lot more diverse and it recognizes all of the important elements of what can contribute to outstanding resident care. And it includes new ancillary services and reimbursement for them, like respiratory care, physiatry, wound physicians, and things like that.
Charles, how long have you been a PDPM lover?
Oh, I got lucky. I got tasked into being the one to teach everybody because I was, of course, like her, the PDPM or MDS nerd. I love the MDS since way back. When I first started reading about it, I was just like, okay, this is what I wanted. This is what I wanted to see the government realize that was involved in care. Because we know that actions follow money. That's just a reality of an economy that we have. And PDPM actually it shone the light on several things. And so suddenly you saw dietitians at the table. Where you said IDT team, Melissa. We saw speech therapists get the place they deserved. And in the past it was like, oh well, they use speech therapists because they can't swallow. Well, now all of a sudden this whole bright light was shined on the problems of cognition. And guess who knows that has 4 years of college and more. Oh, a speech therapist. Hey, we got one of those. It was PDPM paid for that now. So that's where I felt like PDPM. Okay, this is the answer to drive the care. That was the takeaway. The very first time I read through it, I was like, okay, good. Now we're gonna get reimbursed for something more than minutes. Yeah.
Before we went live, you both were chatting about how you read the book. Melissa, can you tell me what the book means, what this book looks like, how exciting is it for you, and how unexciting is it for me?
It's actually in a way unexciting for everybody unless you understand how important it is and how it can ultimately impact resident care. But the things that I look to for resources to learn and understand PDPM in the beginning were the technical expert panel reports released by Acumen, basically the research studies that Medicare did that help them decide how they should design and how they should pay for the different elements under PDPM. And then also reading all of those proposed and final rules, which can be hundreds and hundreds of pages long. There's a wealth of information in there that helps you understand how Medicare got to their conclusion. So if they're making a change, if they're making a payment cut, or as I like to describe PDPM, it's really a redistribution of the wealth. If they're doing something like that, why are they doing it, and how did they come to that conclusion? And I think one of the books that Charles and I have in common is the RAI manual, which is the book that tells you how to complete an MDS assessment. And that is one that has been so valuable to me as a consultant and to my clients at this time, because you can read a small qualification that'll get you some sort of reimbursement and some of the PDPM wording, but you actually have to dive deep into the RAI to really understand how to correctly apply that. And I'll give you an example. Morbid obesity is one that gives us 1 NTA point, a non-therapy ancillary point. And when we add 1 NTA point, that can increase reimbursement anywhere from $45 to $151 a day. I was just looking at that this morning. And if you document morbid obesity, that's not going to count. It either has to be the ICD-10 code that's a BMI of 40% or greater due to excessive calories, and there's another obscure code also. But those are very simple things that if you dive deep into the RAI and look in some of the PDPM documentation, you can determine that, but you can't sort of from the eagle's view from 1,000 feet up.
From Charles, from a kind of learning curve point of view, is PDPM a moving target, or after you've spent 50 hours or 100 hours focused on it, do you get the gist of it and you can become an expert, or is it something you have to read every day?
So that's a good way to ask the question. So yes, but not so much in the intricacies of kind of coding the MDS. Like she said, we have the RAI manual. This is the rule. It's the Bible you flip to, and you go, okay, that's how I code for malnutrition. Or that's what I have to name. But then you do have to take it a little bit further. But malnutrition was a good example because there is a medical diagnosis of malnutrition. There's a lot of clinical indicators of it. So I found myself digging even deeper into, okay, albumin, prealbumin, protein levels, how that starts to get impacted by meds. So to become a better assessor and to actually write that care plan a little bit better, I'm finding myself learning about diagnoses and deeper diagnoses that I wouldn't before. Like I believe there's an NTA point for connective tissue disorder problems or something along that line. Well, that's a lot of different diseases, and I found myself, okay, what actually codes here? And when you start digging in, now I'm in the ICD-10 manual doing deep dives and going online. So yeah, there's plenty to keep learning. You can master coding. Probably maybe a year and a half. You could go from nothing to being pretty competent. When you say, Melissa,
Agreed.
I say 6 months, you kind of have a clue of where to find what you need to know and kind of what you're coding. After a year, you know enough to realize you don't know anything. And after about 2 years, you're like this expert. Everybody comes to you, But yeah, there's so much now because PDPM represents a patient holistically, right? So it's no longer this little focused view, and that's why you got to keep learning.
Yeah, I couldn't agree more, Charles. I'm amazed. I get almost every single day onto the APACN website. These are the people that certify directors of nursing or give you RAC CT certification to become a certified MDS coordinator. And I know so much about PDPM, and there's almost always at least one post that somebody puts up, and I think, boy, I'm not sure what the answer should be to that. This is so deep in the weeds. It's not the obvious weeds. It's so deep. I've got to go back and look at the RAI or look at my PDPM resources and figure out what the answer should be. So while I feel, as I'm sure you do, Charles, I've come a long way, and I've got a mastery comprehension of it. There's so many tiny details that you really can never stop learning or assume that you're totally on top of it, I think.
Right at the moment you think you got it.
Melissa, is there anything that's left for interpretation? Is there anything gray? I know once in a while you get one of those questions that are deep in the weeds, but are you able to find the answer with 30 minutes of research, or some of these it's kind of evolving?
I don't feel like there's a ton of gray with the system. They've done a pretty good job of taking subjectivity out of it. There could be a handful of things here and there, but I honestly can't even think of one that comes to head right now as far as something that's not pretty black and white.
Right.
And one of the things that I find is if I can't find the answer, usually about 10 or 15 minutes, I have an amazing consultant on my team. She's my MDS guru, Melissa Kiter. She's been an MDS coordinator for a really long time. She's an outstanding mentor when we're training new MDS coordinators on site. And she's kind of my phone and MDS coordinator. Anytime I'm not sure, how should we code this IV? She always knows the answer.
Charles, you have a user group call once a month that you lead for all of the super users of our EHR experience care, and you bring up PDPM questions, topics, and concerns. What would you say is kind of the first thing that you help when you're starting to help someone and you're starting to take over as director of customer service that you help them figure out?
With the focus on PDPM,
Mm-hmm.
it's the first part is where your data is going to be. From the people I work with, it's like, okay, how can I get to what I need to know quickly?
Mm-hmm.
And then the second advice I give them is you've got to involve your physician a lot more than you ever did in the past. And as the MDS nurse, because I got to do some PDPM with the company I was with before I came to the vendor side of the world, and I found myself really getting in front of the doctor a whole lot. And you'd asked about the gray area. The gray area almost always falls into the diagnosis piece. It's like, well, is this end-stage liver disease or not? And so now that's a doctor question, right? So it's not that it's a gray area; it's a clinical area. But that was probably the two pieces. Is like, okay, let's find out where your data is. Let's make all of that as available as we can with as few clicks as we can. And then, okay, now you're having a discussion with the doctor about this patient holistically. That's the two pieces I start with usually.
Yeah, I couldn't agree with you more about the ICD-10 codes. And one of the solutions that I found that's been surprisingly impactful is groups that partner with a physiatrist group that comes on site several times a week, participates in therapy, evaluates the resident, and they are very good at coding. And I'm actually working with a large group right now, working with training their docs on intermediate to advanced level understanding of PDPM and ICD-10 coding. And we're just in the middle of working on a research study about it. But the impact is significant in the per diems just by leveraging your access to a physiatrist who really understands the balance between therapy, nursing, physician, and the impact of the ICD-10 code. So I think there's ways to be able to without even necessarily having to ruffle the feathers of your, medical director or the physician on site. You can also leverage something like physiatry services at no cost to the facility.
Melissa, I want you to shout out and mention your podcast. But the specific question they have for you related to your podcast is which episode related to PDPM has the most listens and why?
Well, I must admit, Peter, you've caught me off guard. I don't have the stats in front of me right now, so I'm not too sure. But I do know that one of the most watched episodes we've had in this last season was about the proposed rule that came out this year, which had a lot to do with what they're calling the PDPM parity adjustment. In other words, we paid too much, PDPM was too expensive, and we've got to reduce our future reimbursements to help right size and be budget neutral. So we had a lot of people, obviously, because it's financially related, interested in that topic and wanting to understand some of the insights that we had about that adjustment. The most important one to me is that they want to cut PT and OT reimbursement by 5%, as they do with all the other categories, because they were 5% over in their costs. But PT and OT didn't cost them any more. PT and OT did almost exactly what they projected that they would. So we're hoping that advocacy will help us be able to help CMS to see that it would be devastating for them to cut therapy further, and that they really should be focused more on nursing and NTA.
Sorry, I put you on the spot, Melissa, but I'm going to put you on the spot again. Of the webinars that you've done, because your website, and please feel free to mention the website and the name of your podcast, because it's really, really good. Of the webinars that you've done, which have you got the most amount of engagement? Because you know that it's particularly, either concerning, maybe it's the exact same topic, the future.
Yeah, so our podcast is Gravity Healthcare Hacks, and our focus is on executive leadership in senior living, helping them with intermediate to advanced level strategic planning around any topic of concern, which obviously PDPM is a huge focus for us. We have a plethora of free webinars and white papers on our website, gravityhealthcareconsulting.com. And I think the two areas that we've seen the most engagement with, both when the webinars went live and even after the fact, are people are very focused on NTA. I think people feel like they generally have a fairly good handle on how nursing should be coded and how that impacts PDPM. But I think most people, because NTA is a whole new category under PDPM, recognize that that's the area of opportunity, greatest opportunity for most of them. And then the other one is a series of webinars we've done. It's also specialized training that we do, a more expanded version for clients all the time, called ICD-10 for PDPM. So it's kind of walking people through how to code correctly, not making someone a master coder, but understanding how to interpret ICD-10 coding through the lens of PDPM.
Thank you for sharing that, Charles. I know from working, closely with you for the last year, you're really focused on KPIs and dashboards. Are there any metrics that you're putting into the software for your clients that are tied to PDPM, and which are the ones that you focus on if that's the case?
Yeah, so I think in terms of, so we're having a money conversation now, right, about PDPM, because if it's documented, you can capture it and get some money. So there's this low-hanging fruit levels, and there's some high-hanging fruit. So some of the low-hanging ones are obvious, like malnutrition diagnosis, or if they've had weight loss, or labs and those kind of things that you can flag up. Weight loss is probably the easy one to flag up. Poor meal intake, which will get you in there real quickly to figure out if they got malnutrition. That's when you can activate your dietitian. So things like that. And then, so surprisingly, your KPIs on the dashboard are mostly diagnosis driven or potential to lead you to diagnosis. So you see some functional changes in ADL scores, obviously, then maybe something's going on. I'll also flag up certain medications, and certain medications can lead to different diagnoses. Dementia care and things like that. You may not have the diagnosis, but you may be on the med, and so you can flag up meds missing diagnoses, and the software can actually ask that question. It can say, "Show me people on this who don't have this diagnosis." Those are really good ones to pull forward. So I guess it's a little bit of AI, kind of mini AI, Melissa. The computer kind of thinks for us, or at least goes, "Hey, look over here."
Yeah, I'm a huge fan of that. I'm involved with developing some EMRs right now, and I've worked very closely with some of the well-established EMRs and even some of the well-known MDS scrubbing software. And I think regardless of which way you go about it, you need some tool that is giving you live data analysis for where you are, potential missed opportunities, potential red flags, potential compliance concerns. And, I work very closely with several rehab groups. We also do rehab consulting through Gravity. And one of the biggest rehab EMRs, Net Health, they have a business intelligence platform, which is an add-on. But when you realize how much value it can offer, it's absolutely worth the relatively small expense. And what's important to do with any of that business intelligence, I think you can get access to, is to work with that EMR vendor to customize. So if we as a rehab provider want to know what percentage of our total speech therapy, our patients have an SA, which is the lowest reimbursing category. The total reimbursement per day is less than $20. And most therapy providers are giving the majority of that to the nursing home. So it's a tiny number of dollars and basically support even a couple minutes of speech therapy services a day. So how many of those are we having? Why do we have such a high percentage? What's the state and national threshold for that? Are we over or under? And are patients that are in that category receiving speech therapy services? And if so, is it appropriate? So without using those data analytics to drive you down that rabbit hole, you could be leaving a ton of revenue on the table because maybe you shouldn't have so many essays. Maybe there's missed clinical indicators that aren't being captured by MDS or aren't being documented correctly by the speech therapist, or it's not being communicated very well, or some way the system is broken down. So you shouldn't have so many essays, or maybe they're inappropriately being treated by speech therapy and they don't really need speech therapy services in every case. So I'm a huge fan of using the data and the business intelligence to lead you in the right direction. There's no reason to do it with old-fashioned spreadsheets and manual tracking and trying to stay on top of it. It's way too vast to ever really do that successfully.
Yeah, it is. Yeah, that's my biggest question when I interview somebody who's looking maybe to pick software is, tell me what you're doing on spreadsheets right now. Because if you're doing just basically anything on a spreadsheet, you shouldn't be, and your software should be helping you out.
Yeah, absolutely. Absolutely. And I think it's really important too. A lot of people will look to a post-completion MDS scrubber. So I've already done my MDS, and I'm going to send it to this data port to say, hey, here's a missed opportunity. Here's something you should correct. And that's not as effective as something that's live. So in real time, it's letting you know, hey, today you missed a restorative nursing visit. You were under 15 minutes. That's probably something you want to follow up on it while today is still today to see if you can, appropriately achieve, if it's clinically appropriate, those additional restorative minutes, and then get the appropriate reimbursement associated with it.
Yeah, you actually brought up a good point just now. Is that's another big change PDPM brought, is we're filling out our MDS now from the day of admission. We're not waiting till day 10, 11, 12 when we set our ARD, and we're just kind of looking back. Oh, what did we capture in the chart? We're guiding the story now on the front end, so we have the diagnosis in the real time. We have the minutes we need. We have the doctor answering that question. And you're right, that is different. That is probably, to change my answer a while ago, Peter, that's probably the biggest change, and probably the biggest advice I'd give at this point is you need to, by day 3, you kind of have an idea of what kind of score you could probably get, and you should be working towards getting those diagnoses in place so that your care plan matches what's real. Yeah, so I'm glad you said that way, because I haven't actually been able to phrase that in that way.
Yeah, I think you're totally correct, though. If you're waiting until the ARD or after to begin compiling information, you are going to miss out on revenue. You have to be thinking really from pre-admission, what are the services and things that we need to put in place to best serve the needs of this resident? And oh, by the way, how do we need to structure those for reimbursement? And a good example is restorative nursing. You can structure that for a skilled patient, but you've got to decide on day 1, the day of admission, collaborating with your PT and OT to find out what elements of restorative therapy you can provide that are not going to be provided by PT or OT, because there can't be any overlap, and you have to get them initiated at the latest by day 2 in order to get those 6 out of 7 days in the look back period that are required. So it requires a lot of being light on our feet, really forward thinking, and really investigators. Instead of receiving a file full of information about the patient and then just putting together a report, I really feel like MDS coordinators now have to get out there with their magnifying glass and search in every nook and cranny and try to find solutions and profit areas that are appropriate for the resident. And, CMS said their projections were that it was going to save each facility approximately $12,000 per year, switching from RUGS 4 to PDPM, as far as how much MDS needs they would have, how much labor they would have, right? And I 100% disagree, because every MDS means so much more. It's weighted so much heavier, and there's so much more detail that's required now that contributes to reimbursement, that I think the job has actually gotten harder and a lot broader than it was before.
Yeah, you have to be Sherlock Holmes, and you have to be, as soon as they come through Baker Street door, you're on. Yep, exactly.
Absolutely.
I'm guessing that a lot of this is easier said than done. When you start working with a client, either one of you, because I know you've helped both a lot of organizations, improve their reimbursements. I'll start with you, Charles. What's the first step that you do, given that this is not a process that happens in 24 hours? Do you start with the education? Do you start with the metrics and showing the owner?
Yeah. So really, the first conversation is, I need to explain to you just how important your MDS is and how important your MDS nurse is now. And if you ever feel the need to pull them to the floor, you need to check that need, and you need to find somebody else, because they are that important now to your bottom line, to your ability to capture, to the way your care gets driven, and they become the central communicator in the IDT team, more so than, I think that was always the vision, don't you, Melissa? Is the MDS nurse would run this big assessment. That was CMS's idea, but everybody kind of siloed. Not anymore. They can't silo, and that's the first conversation. The next conversation is, okay, let's make sure we got the right person in that seat. They got to kind of love it. They got to be OCD, and if you got the right person in the seat, then all that's left is education and then support from the administrative team, right? And then it's just your system build. But yeah, I always start with, guess what? This person is probably more important than you are as administrator now, which is Which, and a lot of them would agree with that. A lot of them really would.
Just don't sit in front of their MDS coordinator.
Yeah.
I think actually many of them would admit it in front of their MDS coordinator these days because it's that important. But I totally agree with Charles. You can't undervalue what MDS brings to the table. And, I find that a lot of clients will come to me, and every now and again, I've got someone that comes to me and says, we've already done an audit. We know what our problem is. Can you help us with NTA and ICD-10 codes or something like that? But most of the time they come to us and say, we just don't think we're making enough money. That's basically what they say. We see the national numbers and we're less than that, and we'd like to fix that problem. So it really helps for us initially to just do a really deep PDPM audit and figure out what are they doing right? Where are they falling short? Where are missed opportunities where they got really close but didn't quite get there? And that really helps us to establish, where's education needed? Does somebody need mentorship? What kind of systems and processes or ancillary services can we recommend that are going to help you? And to Charles' comment about, the MDS coordinator really being the orchestra director of everything, I think that really is a perfect example of that is with ICD-10 coding. So you have your doctor putting down the codes that they think are appropriate, and you've got therapy putting down the codes they think are appropriate. And when we think about what the primary ICD-10 code is going to be, that's really the one that requires true interdisciplinary coordination, communication, and gaining agreement, because you have to have that primary code on the MDS match what's on the PT, OT, and if speech is in, speech evaluations. It's very important because if therapy is your primary skillable service and that code does not match the code on the MDS, I think that's a really easy way for Medicare to deny the entire skilled stay and make it really hard for us to win that back. And they've told us to our faces, Medicare has, that's the number one thing they're going to go after is ICD-10 coding. So it's really about the whole team coming together, collaborating on what code they think should be primary, but that MDS coordinator is the gatekeeper. They're the ones signing off on that part of the MDS. And when it's all said and done, they have the final say, in my opinion, on what the primary ICD-10 code should be that's listed on the MDS.
And to add to that, the physician has to document towards that primary diagnosis. And, the insurance companies, they jumped on PDPM real quick. And I had several denials around, well, the doctors treating the UTI that they had in the hospital, and you guys are saying it's related to this dementia and the exacerbation of the Parkinson's because of the UTI. And, both stories are technically true. It just depends on what the clinician says. And we lost money because the clinician wasn't a part of the conversation.
Melissa, I'm guessing that the missed opportunities are probably 75% of the time the same ones. What are the 2 or 3 missed opportunities that you see when you first go in and work with an organization that first month?
You might be surprised to find out that there are not definite trends in that area. One of I think probably the 2 things that I would say, though, that we find in almost every single PDPM audit are lack of utilizing restorative nursing or using it ineffectively for skilled patients, such as only having a restorative nurse there 5 days a week. So you have to have at least 6 days in the 7-day look back period. So you've done almost all the work and now you're not going to get the reimbursement. So that's a really typical one that we find. And I think even more importantly and financially more impactful, to the tune of about $30 to $50 a day, depending on how it impacts that particular patient, is Section GG documentation. So Section GG is the part of the MDS where we tell Medicare this is how much physical care this patient required for self-care tasks and mobility tasks. And what we find is that section is being done incorrectly all the time. The most common error is that they're just taking what therapy reported and putting that in. And that has a couple of weaknesses to it. First off, it's not correct. It's supposed to be an interdisciplinary assessment and include every facility paid caregiver in the report. But it also will artificially drive up your admission level of independence, which reduces your reimbursement. And that artificial inflation at admission makes it look like your functional outcomes are lower than they really are. So we find as a regular recommendation that we're working with facilities to determine how they can incorporate appropriately nursing documentation to really accurately include the heavy weight of what nursing contributes towards a patient into their reimbursement and documentation.
Yeah, you're spot on. That would have been my answers. And that's why on day 3, you've absolutely got to look as a group. And Section GG is one of the things you talk about. is, hey, right now we think it's this, and then give everybody a chance to go, I agree or I don't agree, because yesterday this happened. But yeah, Gigi is actually probably the low hanging fruit now. We did great on diagnosis. I think everybody was obese and everybody was malnutrition really quick, and everybody was pocketing food now, and that because it's tied to money. But yeah, you're right. We didn't quite get there with Gigi, and some of that was because a lot of states still have to do Section G. So Peter, you've had some experience with this as a nurse aide. You document ADLs one way, and then you step over here and you document differently. That's hard too, right? So.
Yeah. But with Section G slated to go away probably next year, it was supposed to happen last year, but the pandemic it got pushed off. I think that a savvy provider will begin to shift nursing documentation over to the Section GG wording. People are kind of scared of it, but we're doing it with Section G now. So why not do it with Section GG? It's the same system and process. It just has the potential to significantly increase reimbursement.
But Charles, you mentioned last week one of the things that you think PDPM has done good in long-term care is it's brought us closer to having a true interdisciplinary team. And Melissa just mentioned that word. Can you elaborate? What do you mean by that?
So, of course, the interdisciplinary team is all the different professions and sciences that come to the table. And I kind of mentioned this a while ago that the speech therapist has a much more prominent place and more appropriate for their skill set. I mean, that requires a bachelor's degree. You really sit down and talk to a speech therapist, they know a lot, and it's more than swallowing. So, and then you also, the dietitian, now you have a person who's really conveying, look at these labs, I think this is related to these meds. They're taking a deeper dive now, right? But they have a stronger voice at the table because it's tied to money. And just this fact that we've all got to be on the same page now, like Melissa said, is if it's documented here and it's documented here, CMS is always going to go the way that pays the least. And least, I made a new word, least. So but they're always going to go the way that pays the least if it's conflicting. And then that's going to cost you revenue, even if you did deliver the services, because we don't live in a world anymore where we can say, well, they didn't get a pressure source, so we obviously delivered the services. That doesn't work anymore. So.
Is there any part of the team that's impact or has been, or their value has been diminished because of PDPM? I'll let you answer that, Melissa.
That was actually the comment that was in my mind. I was thinking about, there's been a misconception that particularly PT and OT don't bring a lot of value under PDPM. There's very few clinical indicators, and most of them are more or less out of control of the therapist. I mean, we contribute to Section GG and we contribute to the primary diagnosis, but ultimately those scores aren't up to us. It's up to the MDS coordinator to make that assessment and put those items in. But what I have found with some of the clients that I've worked with to develop communication systems for them is that if the PT, OT, and speech are communicating everything they know about the patient that could contribute to reimbursement to the MDS, and there's a strong, solid system in place for doing that right up front as soon as the evaluation is done, we see the per diems going up $10, $20, $30 a day in those buildings, because while anyone on the team can contribute information about diagnosis codes or things like that, sometimes the therapist is the one that's picked up on something that nobody else did, or they might have gotten access to the PCP documentation, which sometimes, just as Charles talked earlier about connective tissue disorders, that a lot of times doesn't come anywhere in the hospital record to us, but a patient might mention it, and we can get evidence of that documentation and include it in our plan of care to meet all the requirements and then be able to capture it. So I think a lot of people thought PT and OT were going to sit on the back burner and be relatively unimportant as far as the payment structure, but I actually find that not to be true at all. They're great clinicians that spend a lot of quality time with patients and tend to know things that nobody else on the team does.
Yeah, they definitely. As far as success going home, I would agree too. Probably, I mean, I kind of dote on speech therapists being so important because I've always seen their potential, but the PT OTs, it's tough because patients see a workout as pumping iron, right? But a workout is managing stairs. It's all those things. And if you have a good PT/OT who kind of pays attention and goes, "Oh, you sleep upstairs, so now we got to work on stair training," those two can have the best outcomes and the best length of time before the next rehospitalization. And it is because of what they bring to the table. And they do bring a lot of the ortho stuff. You're right. The connective tissue disorders. Guess what? When I was trying to look up those diagnoses, that's kind of who I started talking to, was the physical therapy folks. It was like, okay, tell me what this is. Why is this? You know, and they know. So.
I would assume that having a interdisciplinary team that is well coordinated and collaborating together definitely has an impact on the outcome of care. Does it have an impact on reimbursements as well for the better of the organization? I'll let you field that one first, Charles.
Absolutely. Yeah. Yeah. Because you're telling the picture, you're telling the story correctly and accurately if everybody's at the table and talking. You also are going to get better outcomes, which we may get to this at some point in this conversation, but I feel like probably maybe as quick as 5, 7, 8 years down the road, we're going to start to see the impact of outcomes affect how much dollars we get to. So capturing the diagnosis is going to be one thing. Not letting the patient get worse because of the diagnosis, I think, is where we're headed. So from that standpoint, from the future, yeah, it's going to be big time impacting our money, how well that IDT team is. And don't forget the family is part of this IDT team. You know, they have to take that patient home and continue what we show them. So, you know, in some ways, family is going to be in control of our revenue at some point. So.
Anything to add to that, Melissa, about how interdisciplinary collaboration might impact reimbursements?
Yeah, I think one of the things that I love about PDPM is I think it made every player equal. PT, OT, speech, nursing, MDS, physician, dietitian, all of us are equally important now. Everybody can contribute in a way that impacts reimbursement. The nurses' aides can. If they're doing section GG daily documentation, or in that wording rather, they can be contributing very impactfully to reimbursement. And so I love the fact that it kind of gives everybody an important seat at the table, and everybody's contributions matter.
And at the macro level, I feel like we have addressed the fact that PDPM is going to affect outcomes. And Charles, you alluded to that. At the individual level, can you give me a specific scenario where 15 years ago, care might have been deficient compared to today, and how PDPM is helping it? And I'll let you start, Melissa.
Yeah, so I think one of the greatest points, a perfect example is respiratory care. So it's always been technically a part of the nursing reimbursement. If therapy was not involved in a case, then that could contribute to payment. But we know that in the old system, 9 out of 10 patients were skilled primarily for therapy services. And so therapy kind of trumped everything else. So essentially, if you provide restorative or respiratory therapy, the patient you're not going to get any reimbursement for that in the large majority of cases. Now under PDPM, if you're providing it correctly and appropriately, you will always get reimbursement for any patient, because nursing is now separated out from the other categories. And so it's actually motivating providers to bring respiratory therapy on their campuses and actually use it in a meaningful way. And what we find is when they do an initial analysis and they think, okay, we need 2 to 4 hours a day of respiratory therapy services. Once you get a respiratory therapist on site and they're able to put their eyes on patients and establish a good relationship with the nursing team on site, they're now getting pulled into other patients' rooms. They're able to self-identify patients that have needs and could benefit from their services. So we're bringing this whole element of extraordinary patient care to the resident, because now we're going to get reimbursed for it. There's great margins associated with it, and it's going to help outcomes. It's going to help functional independence. It's going to improve the resident experience, help us avoid complications. And we brought a whole other clinician onto the team to help us diversify our understanding of that patient and provide better care.
Yeah, respiratory was definitely my first choice too. Peter and I kind of had a conversation around, what changed, and respiratory was the first thing out of my mouth. And you're exactly right. Now the folks who make the decisions about the resources you have available, suddenly respiratory therapy was needed in nursing home. There was a time way back 20 years ago, we had RTs and we had everything right because we were just delivering minutes, as many as we could. RTs went away. And I miss that. And now I'm hearing, hospitals are competing with us to get respiratory therapists. So that's interesting change. So,
Yeah, and there's a little bit of a loophole right now. You are allowed to have nurses that have some extra training, which is very vague and not well identified what that has to be. Some extra
yep.
training can actually provide the restorative therapy services or the respiratory therapy services. And interestingly, John Kane, who's the PDPM lead at CMS, was very surprised to find out that that was actually how the system was structured. This was sort of a background conversation that was had in the last year with him. And he stated at that point that it was his intention to change that in the coming years.
Really?
That's not official policy. That's not something that's, in anything CMS is officially saying right now. But I do think those are the kinds of refinements they're likely to make in the next 3 to 5 years to help with some cost control and to basically make it a little harder for us to prove that we're actually doing something that's above and beyond typical care and thus receive the appropriate increased reimbursement.
Before we move on and to talk about the future and how this might, and what are the changes coming with physicians and compliance and surveyors and auditors, I want to stop and just take a moment to thank our sponsor from Experience Care for sponsoring LTC Heroes in this live stream. Experience Care goes back more than 50 years. They most recently launched Level Up to help their customers with free EHR training that can help their staff understand how to refine their workflows. For fantastic customer service led by Charles Oliver right here with us, free online training and amazing, great workflows, go check out experience.care. Melissa, related to the future, and I'm going to change the question up on you, and I'm going to focus on how do you expect this to change for either compliance or physicians or even surveyors? Are they having to become uber experts in these items? Is it going to affect lawsuits and liability in the future?
I think the answer is yes to all of the above. I think surveyors are going to I think they've already improved their PDPM expertise. And I think as we typically see being involved across the nation with all sorts of clients going through surveys, different states and different teams kind of hop onto one idea. So I could see in a building where respiratory therapy is being predominantly or only provided by nursing, for them to hone in on that and say, hey, do you really have enough nursing hours to support that you actually provided this many RT services, that you said you did this many face-to-face minutes during the day? And I think from the compliance perspective, we haven't even begun to see the edge of the iceberg, not even kind of. I think people are going to be shocked in the next couple of years with the denials they're going to get, that they're not going to be able to win because they didn't make sure their systems were tight, because they kind of went in a gray area somewhere. We've even seen, there's a building I've been working with before we got involved. They had 44 ADRs or denials in 1 year for a small community. And almost all of them were based on one sheet of paper filled out on day 4 by MDS and therapy about section GG. And they both signed it and dated it on day 4. And the window is days 1, 2, and 3. And so even though they had section GG documentation on those first couple days, because that form that matched the MDS was dated for day 4, they lost all of those. And I think that's the exact kind of tiny details that aren't going to catch people until it's too late. And they unfortunately are going to have a year or so before they can get themselves out of that rabbit hole. Charles, what do you think?
Yeah, I agree. The other big change, and it's a welcome change for me, is, as I said earlier, maybe in the pre-call we were talking, I'm working towards my nurse practitioner. Some best practices are just being drilled into my head. PDPM is kind of built on the science, finally, the nursing science, which, only recently got recognized. And so PDPM and all of that is reinforcing that. So I think the flip side of this is, from a legal standpoint and from an outcome standpoint, they're going to be looking back and going, well, the chart was really clear that they did have cystic fibrosis. I don't see anything in the care plan about that. I don't see this. And, now they're going to attribute bad outcomes to what we actually said on the MDS, but that we didn't carry through in care. And so there's going to be this burden of excellent care, which I think we've always wanted to provide. I don't think we've ever been incentivized to use the science. And so that's where I think we're at. But you're absolutely right. Low-hanging fruit exists on both sides of this tree. So if I'm a surveyor and I'm looking at you financially, there's low hanging fruit I'm going to go for. I'm going to go for that malnutrition diagnosis. I'm going to go for those things that require the doctor to be involved. And that's the other thing I would add is the doctor, as we move into PDPM more and more, it becomes more of a medical conversation and a nursing care of a medical problem. And we're going to see the doctors having to be, and not that they don't want to be, it's just that their reimbursement model doesn't give them a lot of time to be at the table with us. But I think we're going to see that change too. You saw this year already the physician rate schedules. We saw some nice changes for direct care provider physicians. So that should be, hopefully that'll carry forward.
Yeah, and
Long answer.
I agree with you, Charles. I think that one of the things that kind of hits every angle is care planning. Surveyors are going to get you for that, and it's going to impact whether or not you can fairly attribute an ICD-10 code and get reimbursement. If you have all the documentation there, but you never care planned it, technically you could get a denial for the reimbursement associated with that ICD-10 code. And so I think it's very easy for us to get hit on lots of fronts for details like that. So buildings need to make sure they've got at least one person, if not two, that are kind of your care plan Nazis that are making sure that all of those care plans get updated and they're appropriate, and we've addressed everything that's captured on the MDS, and we're meeting the residents' care needs through those care plans, but also just making sure those administrative details are also met.
Let me ask you a question, Melissa, because you said about the care plans, and since you're out there consulting, are you still fighting the battle of people saying, no, the DON doesn't want the care plan to be real specific?
We do find that, and I think you and I probably have the same answer to people, which is it has to be specific. It can't be cookie cutter. And if it is cookie cutter, to me, that tends to be an example of a culture where the care is cookie cutter. That's not always true. I don't want to paint a broad brush on everybody, but we have found that those things tend to go hand in hand. When you've got a good MDS coordinator that's kind of gatekeeping over the care plans and is reviewing them with a sensitive clinical eye, you can identify all sorts of special needs for a patient and meet their needs in a unique way that is really resident focused, rather than this is how we always address malnutrition. Well, what are the ways that this particular patient is going to benefit most for us to address that malnutrition?
Right. Yep.
Thank you both. I want to wrap it up with some lighter questions, and I didn't give either one of you warning on one of the questions. One of them I did, which was, how do you explain? And I'll start with you, Charles. How do you explain PDPM to someone who's not even in healthcare, not even in long-term care? How do you explain it to them?
So it's almost like the MDS nurse. If you're a baseball fan, you remember the baseball cards with all the stats on the back. PDPM and the MDS coding is kind of the stats now for that patient. That's one way to kind of see it. I think as simplified as I can make it. And it takes a lifetime for that baseball player to get those numbers. Well, the informational MDS is a lifetime of information. So
Charles, does anyone under the age of 40 know what a baseball card is?
I don't know anymore.
I have a lot of baseball cards, and I'm pretty sure my son's not going to have any. Melissa, how do you explain PDPM to your neighbor while you're celebrating Christmas?
Yeah, I think I mentioned this earlier, but I like to refer to it as a redistribution of the wealth. So we basically took the focus away from only PT and OT and somewhat speech, and diversified it particularly towards nursing, and also including some of the ancillary services that we talked about today. I also like to say the transition has been somewhat like chess to checkers to chess. We're on the same playing board, but the rules, the playing pieces, the strategies for success, the level of high strategy thinking that has to be involved to actually win the game, if you will, is so much more significant than it was under the old system.
Thanks for sharing that. My last question before we sign off here, because I know that I only have about 5 more minutes left with both of you. And thank you so much for spending your Wednesday morning to geek out on PDPM. Do either one of you have a PDPM joke?
A PDPM joke.
Wow. I don't think I have one. I have to say, I'll be honest. I don't think I have. But 5 minutes after we get off, I will think of one and I'll share it.
Yeah, probably.
Yeah. And if you were going to, well, Melissa, what's your right-hand woman who's amazing at PDPM that you always go to for difficult questions? What was her name?
Melissa Kiter. She's an MDF coordinator and director of nursing.
If you were going to try and stump her with a PDPM question, what would you throw at her? Would you throw an acronym? Would you throw something that seemed gray? Would you read some latest news or some type of PDPM rate? What would you throw at her to try and stump her?
Yeah, I probably would dive into the financials with her because she's somebody that understands this pays more than that, but doesn't necessarily always follow up on how much of an impact that is. So I could probably stump her with that side since that's more the avenue that I have the expertise in. But I'll tell you what, it's pretty hard to stump Melissa Kiter. She really knows her stuff, and that's why she's a wonderful part of our team.
Well, thank you both so much for joining me. I look forward to talking to you both and connecting with you in the future about PDPM or another topic, and hopefully be meeting you at a trade show in 2022. Thank you, Melissa. Thank you, Charles.
Thank you.